This patient was referred to us for endodontic retreatment of tooth number 15. According to the patient, the bridge is 3 years old. After the bridge was placed, tooth number 15 had started to hurt. So she had gone back to her general dentist, and her general dentist, according to the patient, referred her to an endodontist. And 3 years ago, the endodontist had gone through the bridge and done this root canal. Patient states that the endodontist admitted that he could not get some of the roots. That's what the patient tells me. Patient says she asked the endodontist what that meant, and the endodontist said it meant nothing if the tooth didn't bother her. And patient says she didn't understand it, but she accepted it and left. Well, fast forward 3 years later, a couple of weeks ago, tooth starts to hurt, and patient goes back to her dentist, and her dentist says, well, your tooth is abscessed and the root canal needs to be redone or extract the tooth. And patient doesn't want to extract the tooth because, as you can see, it's an abutment to a 3-unit bridge that's only 3 years old. So patient says, please, I want to try to save the tooth, and the general dentist refers the patient to us. So as you can see here, again, tooth number 15 is an abutment to a 3-unit bridge. You can see the previous root canal. You can see the periapical relucency here. What else do you see? Well, you can see that the endodontist did an instrument all the way to working length. Here on the mesial buccal root, was able to locate the palatal canal, but where is the distal buccal canal? Well, take a look here. You can see that this endodontist gouged the pulp chamber floor so much, hoping that he would find that distal buccal canal, and he could not. He couldn't find it. You can see how much gouging was done here. Look at that periapical relucency there. But the distal buccal is somewhere around here, but this endodontist gouged the heck out of this, removed so much dentin basically to try to locate that distal buccal canal, and he couldn't. And the MB canal that he found, look how short he instrumented and then obturated the canal. And again, you can see the periapical relucency. So we discussed options with the patient, and patient really wanted to try to save the tooth. So that's what we did. Take a look. And here's the post-op. So we were able to actually locate that distal buccal canal that this endodontist had missed. And then we were able to regain patency in the MB canal. I troughed for an MB2. It wasn't there, but take a look here. Look at that. Right off of the MB canal, look at that bifurcation. This is the power of 3-dimensional instrumentation, irrigation, and obturation. So we're able to regain patency in the MB canal. We're able to capture that bifurcation there. We were able to locate the missed distal buccal canal, and we enhanced the palatal canal. As you can see, look at the palatal canal and its complexity or complexities in the apical couple of millimeters. Again, here's another angulation. And I went ahead and placed some composite material here and over the canal orifices, just to make sure that I know most General dentists don't use a rubber dam, and in this case, tooth number 15, I just didn't want saliva and bacteria to contaminate this beautiful endodontic retreatment that we did for this patient. All right, so as you can see, again, everything went beautifully. We were able to achieve all our goals and then some, and temporize the tooth and refer the patient back to her dentist for the permanent restoration here. And I'm optimistic that this periapical relucency will heal over time and patient's symptoms will go away. You just don't expect this kind of treatment from, what I showed you pre-op from a fellow endodontist. You just don't expect that, but we made it right for this patient.